Can you hear me clearly?
Yeah, we can hear you clearly. Hi, Dr. Anand.
Hi, good evening.
Yeah.
Now, do I screen share or IAP will screen share? We just have to figure that out. Hold on 1 second. I'll rejoin. Just give me a second.
Oh,
Uh,
Hi.
Hi, good evening.
Hi, Dr. Sandhya, Dr. Deepa.
Hi.
Hi, Dr.
Hi.
Anand.
Hi.
Hey, Anand, you are from BJMC.
Yeah, I'm from BJMC, sir.
Arey, Charul messaged me.
Yeah.
Anand was our student.
Yes, sir.
I said, why? Wow.
Why? How? Why? How?
Why nahi? Wow.
अच्छा, मतलब why?
Why I was not aware, rather.
अच्छा.
I must say.
Yeah.
Great.
Yeah,
Nice to have you.
Chetan is supposed to know the horoscope of every pediatrician who comes out of Gujarat.
No.
India and abroad.
BJMC 8, at least we should
We
be
should
knowing it.
correct.
I have last minute preparation still pending. I have to go through your TVs.
It's okay.
No, not
You
okay.
can just give our names and then we can start. No long
नाम ही
introduction.
काफी है. दीपा के लिए ठीक है, बाकी सबका बोलना पड़ेगा ना.
हाँ, वो ठीक है. दीपा
संध्या
के
के लिए भी
लिए
काफी है. मना कर रही है.
ये वॉल्यूम ठीक है?
Yeah, good.
ओके, ठीक है.
डॉक्टर संध्या, आपका आवाज नहीं आ रहा है.
Is it?
नहीं, आप बोलो तो आवाज आएगी ना.
Hi, good evening, everyone.
That's okay, fine. Just rename yourself, no? Dr. Anand, Dr. Sandhya, you, both of you.
क्या दिख रहा है इसमें?
Go on the participant and there's 3 dots. I think there you can go and rename yourself.
अच्छा, it's showing only doctor.
So the same link must have been forwarded to your email, no? When I sent them.
डॉक्टर आनंद, आप बैंगलोर में कहाँ हैं?
First hospital, Shampur.
It is in main Bangalore.
Yeah, it's main Bangalore. Yeah.
So there is another Dr. Anand who is
There are 3 Anands in
From St.
Bangalore from
John's.
Hemonc.
yeah.
Anand
From
Prakash is
St.
in
John's.
St. John's.
Anand
Anand Casey
Prakash,
is in
right.
Shankara Cancer Center.
Hmm.
Anand Casey. So I am the third.
Manipal, I think.
I'm the third
With
Anand.
Dr. Bhaskar Shenoy, right?
No, I mean, not Dr. Bhaskar Shenoy is in Manipal. Anand is in, one Anand is in St. John's, another Anand is in Shankara Cancer Institute.
Achha.
And me, I am the third.
Right. So I was in St. John's. That time Dr. Anand Prakash and me were contemporaries.
Yeah. Anand Prakash and me
And
were like contemporaries in Gangaram, Delhi.
Achha. Right. That was some 15, 16 years ago.
So Anand, which hospital are you in? Yashwantpur?
Persh, ma'am. Persh Hospital.
Okay.
So initially we were in Fortis Bannerghatta.
Uh-huh.
In 2018, we were in, we as a team, like 4 of us, we were in Bannerghatta Fortis. And then we moved to Sparsh Hospital since last 4 years.
Okay. Yeah, I'm coming to Bangalore actually, 9th and 10th. We have a meeting there.
Oh, okay.
Dr. Vaidya sir is there.
Hi.
Hello, sir.
Hello, sir. Hello, sir.
Hey, Dr. Rajendra.
Hi, Chetan. Hello. Sir.
Good evening, sir.
Good evening.
ये मंथ पूरा मैं जैसे वेडनेसडे विजडम जितना एक्टिव रहना पड़ेगा मुझे.
Yeah, definitely.
ये मोहिते सर ना पूरा इसकी टोपी मेरे पे डाला हुआ है ना, हेमाटोलॉजी की.
Yes.
चेतन, ये शेयर स्क्रीन मुझे करना है कि वहां से होगा?
नहीं, आप करोगे.
तो
You can do it here.
okay, I can do it. Okay.
Just check it out, no? Once.
Otherwise, you will ask the DIP people. They will make you host.
No, it is working.
Can you see?
Yes.
Yeah.
Dr. Shirisha is not joined, no?
So I'll stop share now.
Yeah.
Okay.
Nilima is also not joined, no?
Hmm.
Arey,
No. Mahesh is going to join, no? Because that
Dr. Mahesh Mohita has not received the link, he says.
Achha, achha.
He will receive soon.
Upendra, I think, is not able to join today.
He is not going to come today.
Yeah. West zone कैसा होगा चेतन?
Acha raha. I was there for day of inauguration. Next day I came back. It was good.
Mahapidikon, you are coming?
Mahapedikun, I'm not been there.
Achha.
Not been invited. It is on 9th, 10th?
No, it's on 13, 14, 15. Next.
Okay. No, not yet.
That's.
Good afternoon,
Hi,
Dr. Mohita.
hi, Mahesh. Hi.
All are joined.
Dr. Shirisha has not joined yet.
Should I call her?
Evening, Mahesh.
Please, if
Yeah.
possible, yes.
Yeah, she's just logging in. Hello, Chetan, why can't I see myself on the screen? Do you guys see me properly?
Yeah.
Yeah.
So why so?
I don't know. That's what I'm trying to figure what happened. What did I click wrong?
Do one
View.
thing, no?
View.
Now it is
Video
only 1 minute left. You can log out and log in again if possible.
No, it's fine. I'll figure it out.
You have checked your presentation?
Yes.
Yeah.
Yes, we have checked. Now I can see.
Okay.
Just in case I'm looking at the roof or something.
Oh. I think it's 4 o'clock. I don't think today Dr. Willebrand is going to join.
Yeah, they will start.
There's a EV meeting going on.
Yeah. I think we'll start.
should start,
Mahesh.
right?
Yeah, yes.
Yeah. So good evening all the viewers of IIT. Yet again, we are here for our Academic Pearls, Tuesday Academic Pearls of 2023. The President Action Plan of Dr. Upendra Kinjavadekar, the IIT, Central IIT President of 2023. And today onwards, in the month of October, this is going to be a series of sessions on hematology. And we are starting our first session with, I would say, reasonably a common emergency or maybe kind of academic challenge that we commonly see in our clinical practice. That's a bleeding child. So this is not a traumatic bleeding child. This is about the bleeding child by pathology in hematological kind of situations. And I'm sure all of us are seeing this day in, day out in OPD or the IPD, and also in the critical cases in the ICU, may it be a neonatal or a pediatric intensive care. It's a reasonably common thing, and it's not only a standalone problem, many times it's a complication as well to other systemic disorders. So to tell us about that, we have esteemed faculty here. It's going to be a panel discussion. So this time we are starting hematology with a panel discussion. unlike other series where we used to have a standalone lectures to start with. And we have a group of experts and panelists. And I request Dr. Chetan to introduce our faculty. It's over to Dr. Chetan.
Thank you, Dr. Mahesh. Good afternoon, friends, and welcome to yet another episode of Academic Pearls, which has been a brainchild of our own president, Dr. Bhupendra Kinjavadekar, and it has been nurtured very well by our convener, scientific convener, Dr. Mahesh Mohite sir, and it has been supported by our team. We know that Dr. Abhay, Dr. Nilima, and all are there, Dr. Rajendra, all on the screen. So it's going very nicely. It has been very well appreciated program all across the country. So now, as Dr. Mohite sir said, that this time we are going to have the month of October as the month of pediatric hematology. So we have topics which are pertaining to this particular segment. And for that, we have a first in this series of 5 weekly webinars for hematology. First is a panel discussion. Panel discussion is on a bleeding child. And this is not going to be a routine the talk where we are going to discuss a theoretical part. But when we have expert pediatric hematologists and the pediatricians on the panel and as well as moderator, it is going to be, of course, a case-based discussion. And whenever it is a case-based, we know that it's really good for our understanding. So we have a wonderful, panelist. First, to start with, Dr. Shirisha Rani. She is a pediatric hematologist and oncologist from Hyderabad. She has been there as at a Rainbow Children's Hospital, Hyderabad, and she has many laurels to her name, and she has been trained at London also. So welcome, Dr. Shirisha.
Thank you, sir.
Then we have a pediatric hematologist from Bangalore, young Turk, that is Dr. Anand Kumar. He is again a pediatric hematologist, and he has been working as a pediatric hematologist and oncologist at Spurs Super Specialty Hospital, Bangalore. We have our own representation. That is because we all know that we all are pediatricians who are listening to this particular webinars, and for that matter, we have to have our own representation. So for that, Dr. Sandhya Gupta, she is from Greater Noida. She is a pediatrician with a special interest in vaccinology and pediatric hematology, and she has been attached to Apollo Hospital, Greater Noida. So welcome, Dr. Sandhya. And finally, we have our
Noida,
boss.
sorry.
Pardon?
Noida, not Greater Noida.
Sorry. Noida only. So, and finally, we have a boss, that is a moderator, Dr. Deepa Trivedi. She is a pediatric hematologist. She's been, she's having something common with me and Anand, that we all three are BJMC pass out from pediatrics, Department of Pediatrics. And she has done her, DM, pediatric hematology from New York. She was there, and then we were fortunate to have her in India, back in India. So welcome, Dr. Deepa, and I'm sure that you are going to make the things very interesting, and it will be very fruitful discussion over the bleeding child case-based discussion. Thank you so much, and it's over to you, Dr. Deepa.
Thank you very much for the IAP team and for everyone to give us a chance to discuss this very common topic. I'm going to start sharing my screen now. I hope it's visible. Done? Yeah, okay, let me start. So,
Make it full screen, Dr. Deepa.
I have it as full screen, but it's not showing the slideshow. Hold on. You can see the screen?
We can see the screen, but not the full screen.
Full screen.
The PPT is not full screen.
Okay, hold on.
Go on the slideshow.
Now?
Yeah, I think that was.
Yeah.
Yeah, now it's okay.
Yeah. So I think we have a good mix. Do you have residents and students also who attend?
Yes, there will be residents as well.
Yes, GNP residents. So let's start
very
with
few, mainly practicing pediatricians.
Practicing pediatricians. So just let's go over briefly on the hemostasis. So we should first understand what is hemostasis. And now we used to have the bleeding and the clotting, but now we call it primary and secondary hemostasis. So Dr. Sandhya, I'll start with you. Can you briefly go over what is primary hemostasis?
So this is a state where there is some trauma. In a normal state, through the blood vessel, platelets and all cells are cruising comfortably. Whenever they sense a trauma where subendothelial collagen gets exposed, these platelets here, they come into action, and the first step is adhesion. I'll discuss a bit about receptors because their pathology is what is causing the clinical symptoms that we are going to discuss. So the receptors that are responsible are glycoprotein 1b, that is causing the first step, adhesion, through von Willebrand factor to the subendothelial collagen. There is another receptor, GP1A2A, which is directly attaching to the collagen. So this is the first step, that is adhesion, when a platelet senses problem. That results in activation, trigger, release of molecules, release of granules, and these platelets swell up, develop pseudopods. That's when it invites other fellow platelets to combine, come together, that there is an issue, and form an aggregation, that is the primary platelet plug, that is facilitated by another receptor called GP2B3A. This is otherwise lying in an inactive state, but when again on sensing injury and exposure to the collagen, it gets activated in the presence of these granules and the factors that are released upon after the platelet is activated, which results in aggregation. So aggregation, this platelet to platelet interaction, can we go to the next slide? Where platelet form an aggregated plug together, and there is this fibrinogen monomer which is floating as a single monomer, and then it gets activated in an activated platelet. It gets to attach the GP2B3A. So two platelets clump together with an intermediate fibrinogen molecule. This is the primary plug, and through the von Willebrand factor intermediating between the GP2B and the underlying collagen, this platelet gets adhesion to the subendothelial collagen. So this is a weak plug. This is primary hemostasis. This is very quick, but not as robust. So if it is trivial trauma, very well can be handled. But if it is something severe, then secondary hemostasis has to come into play.
So Dr. Anand, now that we have a little small platelet plug, what else is expected in a normal hemostatic pathway? You're mute, Anand. Unmute yourself.
Yeah, sorry.
Yeah.
So, so once the primary hemostatic plug is formed, already the coagulation pathway cascade is set to run. So the picture, the cartoon that we are seeing is actually the in vitro kind of test, prothrombin and partial thromboplastine test that we do. It depicts that, but in the body, it is totally different. So I'll just go through the cartoon that we have put over here, and then go to the actual coagulation cascade that comes in. So there are two pathways, intrinsic and extrinsic pathway. The intrinsic pathway is triggered with the negatively charged substances, like when you put a kaolin or a silica, and then the segments factor 12, factor 11, and factor 9 are activated, ultimately leading to activation of factor 10. But in the extrinsic pathway, the tissue factor is there, and thromboplastin is an analog in the in vitro test, and then this will lead to activation of factor 10. So finally, when the factor 10 complex is formed, this along with the activated factor 5A and thrombin will calcium and platelets will convert the fibrinogen to fibrin. This will form the this will affirm the primary hemostatic plug that is already formed, and the further this clot is stabilized by factor 13. So this is the cartoon that we are seeing is an in vitro picturization of what the test we do. But in actual body, there is a 3-step procedure, that initiation, amplification, amplification and propagation. So initiation is like with the tissue factor is getting activated and factor 7A is activated. This along with these both activate factor 10, and along with factor 10 and 9, there is a small thrombin that is formed, and these activate further platelets and the other coagulation cofactors like factor 10, 5, and along with this, the prothrombinase complex on the platelet surface, they will further convert this fibrinogen to insoluble fibrinogen to soluble fibrinogen to insoluble fibrin, and then the factor 13 comes and stabilizes the clot to prevent any sort of leakage from the site.
Yes, I think that is very important. I basically put this just for people to remember. Many times we see people doing only PT, only PTT. Some people miss out the fibrinogen. So since everything is interconnected, at least for the first time when you see a child with a coagulation disorder, please don't do only PT or only PTT. Then somebody gives factor A, vitamin K. Somebody will give FFP, and then we are left searching for why there was a coagulation abnormality. So it's very important to remember that multiple factors are involved. There are multiple pathways, but at least when you send off your basic coagulation workup, you must send a PT, an APTT, and a baseline fibrinogen at least, and collect extra sample properly for additional tests. So thank you, Dr. Anand. So let's start with our first case now. LB was a well child till 3 days ago. Came to the OPD with epistaxis and which had stopped, ecchymosis over his body. There was no other fever or symptoms. The kid was looking well and playful otherwise. So Dr. Shirisha, please tell us something very important since we're having this dengue season. We're seeing children with fever, some with petechiae, some without petechiae, some with low platelets. So what should we remember when a child comes to you?
So when the child comes to us, of course, it's important to note what season we are in and whether it is dengue or non-dengue season. That is one important thing. But otherwise, in general, we have to approach like, when the child is bleeding, is that bleeding significant for me to investigate or not? Some of them will have repeated nose picking. They bleed at times, even significant quantity. They do bleed from little's area and they come to us. But it's a single site bleeding, no, not multiple site, non-consanguineous, and no other side bleedings. And going by that, at times you can decide on not investigating the child at all. If there is no significant family history, non-consanguineous child, no multiple site bleedings, then you can decide on observing the child. You can always have to educate them, counsel them when to come for the medical attention again. And once we decide that, oh no, this is a significant bleed, I have to go ahead and investigate. We need to question ourselves. Is it a primary or secondary hemostasis? Dr. Sandhya and Dr. Anand nicely explained, about primary and secondary hemostasis. So we need to decide whether it is primary or secondary. We need to know nature of bleeds of primary and secondary. Primary generally will have petechiae, superficial or mucosal bleeds, and whereas secondary deep-seated bleeds, like knee bleed, hematoma, muscle hematomas and all. So going by the nature of the bleed, we need to go ahead and decide which direction we have to go ahead and investigate. And the next step we have to think is is it an inherited problem or is it an acquired problem? Starting at young age and once again born to consanguineous parents and strong family history, these and multiple episodes requiring transfusion, intervention. These are the things that says that this is an inherited problem rather than an acquired problem. So, but it's our index case. All of a sudden, in a otherwise well child previously, it has started. The episode has started. Then it indicates that it is an acquired problem, and it looks like petechiae and mucosal. It indicates that it is a primary hemostasis. So, primary hemostasis, acquired primary hemostasis, it is a ITP most of the times. So that is how we need to go ahead and think it just takes 1 minute, but we just have to put the thought process and think what condition we are dealing with. In dengue season, definitely, yes, we have to think about when to give the platelets. If you look at WHO recommendation, the platelet transfusion is not different for dengue. But however, because as we know, most of the time they drop the platelet after the fever subsides. If the fever is ongoing with coagulopathy, then you always suspect is there a secondary HLH post-dengue or is there a secondary infection that is there on the board, then we have to go ahead and treat aggressively and then we give platelet transfusion and other supportive care.
Okay, thank you so much. So, Shirisha, this is again very important when we take history and especially for the residents. Petechia versus purpura, what is ecchymosis and what is hematoma, briefly. And what is the blanching test and what it helps to differentiate.
So, petechia basically less than 2 millimeter size, pinhead size, to be precise. We can't measure with the tape for every child, but just a pinhead size is the petechiae. And ecchymosis or bruise are something which has bleeding underneath the skin. So blood underneath the skin. So anything more than 2 mm, especially more than 4 mm is like, bruise or ecchymosis. When it is spread to wider area, then it is ecchymosis. Bruise and ecchymosis, most of the times the pathophysiology is same, but the size is little different. Bruise is like more like localized, and ecchymosis is more widespread. Blanching test is well demonstrated over there. Like, when we press with the glass, then if it is not blanching, then obviously it indicates that the blood collection is there underneath the skin. Whether it is petechiae or purpura, both will be like non-blanching.
Yes. So most viral infections, usually they blanch. So if you have
Yes.
infectious disease, it is usually blanching. With a hematological disorder, it is less likely to blanch. So I think this is very important when you write the history, how many bleeds, how many ecchymosis are there on the body. So that has to be written. So we know the severity and whether to treat or not to treat. So Dr. Anand, tell us something. Peripheral smear importance. Again, we see a lot of places where the pathologists don't see the smear, where the automated machine gives you the printout. So how important is a PS in a patient with hematological suspected disorder?
Very, very important, I would say. This is the basic and the most widely available, cheap hematological tool that is available for a practicing pediatrician, even at the remotest area. But the pathologist should be experienced, or at least the pediatrician should have basic knowledge about the peripheral smear. So when it comes to so you have a child coming to you with a CBC report saying she has a low platelet of around 15,000 without any symptoms, then you question whether it's a pseudothrombocytopenia. So that should be a first differential. So what I would see is, when you see a peripheral smear, I would see whether there are any clumps or catalytism that happens in some cases around the RBCs with EDTA sensitivity. Or so platelet size, sometimes giant platelets or microplatelets you have to see. So along with this, so this would just give us idea whether it's a true thrombocytopenia or pseudothrombocytopenia, or sometimes give us a clue regarding the nature of the disease, like inherited thrombocytopenias like Grandson's, Bernard-Sollier kind of thing. If they don't clump, usually some form of clumping you expect in platelets. If they are very singular and very spread out, then it could be a platelet function disorder. And of course, granularity, we have granulation disorders in platelets. That is a very rare, but still can occur. And sometimes the peripheral smear will give us the etiology towards the diagnosis. Like you have mentioned, that if you have a helmet-like cells or cystocytes on the peripheral smear, along with thrombocytopenia, along with AKI or a seizure patient, it's a case of thrombotic microangiopathy, you're dealing with TTP. And if you have a vegetarian person coming with low platelets, and you see a larger RBC along with low platelets in a vegetarian population, most prominent in Gujarat, where it's a lot of population are vegetarians. You expect megaloblastic anemia there. And of course, if the patient is icteric and gives a sudden history of drop in the hemoglobin along with the drop in the platelets, and you see spherocytes and with thrombocytopenia, it could be a case of Evans syndrome wherein DCT would be positive. And these are some of the simple clues that we can keep in mind when this, of course, I'll talk about I think we have a slide about WBC. We can talk about WBC.
Hello. Yes. So in this child, a peripheral smear was examined. It showed some hypochromic anemia, severe thrombocytopenia. The platelet count was 5,000 with few giant platelets. There's some relative lymphocytosis and some reactive looking lymphocytosis. Again, it is very important when we talk about peripheral smear evaluation in thrombocytopenia. The manual platelet count and the platelet count given by the machine automated are often not the same, because the giant platelets don't get counted by the machine. So again, this is very important when you see a patient with a platelet count of 5,000 to not panic. And the parents freak out, the pediatricians also freak out. But sometimes if you look at the manual, you might get 12,000 or 15,000 count. So again, it's very important to ask the pathologist to see the smear and give you a manual platelet count along with what the automated gives you. So Dr. Sirisha, what are the two things that you see in this peripheral smear?
So in the upper one, you can see red cells as well as white cell. that's a reactive lymphocyte. Whereas in the lower one, red cells and giant platelet.
Yes.
So giant platelet, usually I'll tell our students, like, when you see the peripheral smear, you look at 3 cell lines: red cell, white cell, and platelet. So when the size of the giant platelet, as with the name itself indicates that it is a big. So when you can't fit it into the white cell and red cell, of course we can make out. Then it is giant cell, giant platelet. That is how you can recognize. That's a simple way. But otherwise, like when you keep repeatedly looking at it, then you can make out. Yeah.
Yes. So again, it's very important to see the smear, to see giant platelets, activated lymphocytes, which can again be seen usually. Dr. Sandhya, what are the red blood cell series what are the clues that you would look for in a peripheral smear? If you have thrombocytopenia also.
Yeah, so what not to miss is the concern here, like discussed in earlier also, that other 2 cell lines also have to be seen. Some of the specific cells that we should look for in peripheral smear, which can be a marker of hematologic emergency, is what we are going to talk. So one is schistocytes, has already been discussed. Microangiopathic hemolytic anemia. If significant number of schistocytes are seen in peripheral smear, they have that corner appearance, 2 or 3 corners can be there, spur-like appearance, and they are fragmented cells. So the name itself tells that the red blood cell is somewhere getting a shear stress while passing through the vessels and is getting fragmented. If that is present, then has to be picked and not to be missed, because it is a marker of conditions like TTP, thrombotic thrombocytopenic purpura, and can also be seen in HUS or mechanical calcified heart wall. So wherever there is a shear condition present in microangiopathic hemolytic anemia, schistocytes should not be missed. And then it may not be a simple case of isolated thrombocytopenia, but look for more problems. Other peripheral smear finding can be teardrop cell. As the name suggests, it is in the shape of one blunt end and one pinched appearance of RBC. So this is a marker of bone marrow infiltration, where if there is more connective tissue present in the bone marrow and red blood cell is trying to go into circulation, in the process getting squeezed and getting a tail. So if significant number pointing to different directions, teardrop cells are seen in RBC, look for problem in marrow. And there can be infiltrative disorders, malignancies, fibrosis, myelophthisic syndrome. So definite more workup is needed there. And nucleated red cells, these are the immature RBC. So mature RBC does not have a nucleus which is present in circulation. But if for some reason this immature RBC or normoblast is being put into circulation, there has to be some problem again, either at the marrow level. So marrow can be infiltrated here, again fibrosis, or marrow is in a hurry. Like if there is severe hemolysis or acute hemorrhage, marrow is in a hurry for rapid turnover, taking out more and more immature cells. So any nucleated red blood cells beyond the newborn period should definitely be worked up.
Thank you. Yes. So as Sandhya was saying, these are schizocytes, which are helmet-shaped cells. Here you can see one of them, because of which we can consider that this is a teardrop cell, and we can consider that this patient is having a microangiopathic hemolytic anemia. You look at creatinine, see a history of any diarrhea was there. You can have E. coli-induced sepsis, which can give you a hemolytic anemia. So Dr. Anand, can you tell us what we should look for in the WBC series?
Yeah, I think it's very important to have a knowledge about the white blood cells in the peripheral smear, especially when you're trying to decide whether to do a bone marrow or not. So very important. So when you see atypical cells, blasts in the peripheral smear, it's a red flag that you are not just dealing with simple thrombocytopenia, you're probably dealing with a leukemia. So it is pertinent, or it's a very absolute indication to do a bone marrow. And sometimes in case of infections, they should a left shift wherein there are a lot of band cells. It happens in infections or sometimes myeloproliferative disorders, which is rare in children. And most of the children are coming from a viral infection, antecedent viral infection. Usually it's typical history that we get in ITP. You see some form of reactive lymphocytes that we have already discussed. And dysplasias are quite rare in children. Of course, you do see sometimes post-infections or some micronutrient deficiencies, or sometimes marrow disorders, very rarely. And of course, when you see a white cell morphology, sometimes you see these Dole bodies. Again, you can see in some infectious disorders or in some macrothrombocytopenias like Meheglin anomaly, or you can see some giant neutrophilic granules in Chedet-Hayashi-like syndromes.
Thank you. So again, it's very important. This is why the peripheral smear has to be seen, even if there is only isolated thrombocytopenia, to rule out any other causes. So Sirisha, now we have decided this patient's white cell is normal, series is normal, RBC is okay. So now it's isolated thrombocytopenia. So what are the common causes of thrombocytopenia?
So thrombocytopenia by mechanism, we go ahead and divide them into impaired production. Impaired production can be secondary to marrow infiltration like leukemias, or it can be secondary to marrow aplasia, or it may be secondary to deficiencies also, where there may be an impaired production. On the other hand, it can be secondary to consumption as well. And in impaired production, you also have post-chemotherapy, one of the reasons. And then second is secondary to increased destruction, peripheral destruction, typically like ITP in this child. And third is distribution. In distribution, you have hypersplenism. So this is one way of classifying. On the other hand, and hypersplenism can be secondary to any cause, it could be thalassemias with a big spleen, or it may be myeloproliferative condition, or it can be storage disorder, or it can be metabolic condition. So any of the condition can lead to hypersplenism and cause trapping of your cell lines in the spleen. And other than that, you can also divide them as infections, infiltrative disorders, drug-induced, and systemic causes, inflammatory conditions. So that is another way of classifying the going by etiology of thrombocytopenia. That is another way of classifying the thrombocytopenia.
So yes, it's very important now to figure out what is the cause of this thrombocytopenia and then go ahead with what kind of workup that is required. So Dr. Anand, what are the common causes of peripheral platelet destruction? Now we have ruled out maybe that the marrow is producing normally, there is no hypersplenism, there is no HS megaly. So if we only think of isolated platelet destruction, what are the clinically common causes that people should think about?
The most common cause is and will be ITP. So that is a peripheral platelet destruction through antiplatelet antibodies. And of course, importantly, drug history has to be taken when they are coming from maybe a malaria endemic place, or they have received quinidine, or they have prolonged antibiotic use, and are they receiving anticonvulsants, because they could be a cause of a drug-mediated antibodies causing peripheral destruction. And third, it could be a part of an autoimmune disease, like it could be part of SLE, or it could be a part of ALPS thing, and sometimes viral infections like HIV can cause isolated forms. And most of the seasonal fevers like dengue also can cause peripheral destruction and cause thrombocytopenia.
Okay, so again, it's very important. Once, at least you must have one kind of a differential diagnosis when you have to approach the patient. So Sirisha, as we had spoken, the size of the platelet is very important. What clues do we get when you see the size of the platelet?
So one is so going by size of the platelet, is it a giant platelet, that is MPV, is it high? MPV between 6 to 12 is normal. Anything less than 5 or less than 5 is a microplatelet. Above 14 is megaplatelet. So if you have megaplatelets, that is giant platelets, uniformly megaplatelets in the smear, then it goes more in favor of Bernard-Follier syndrome, or other syndromes where it is a megaplatelet inherited thrombocytopenia conditions, MYH9 anomalies and all. So those are will come into picture in that situation. If it is micro, that is MPV is less than 5, then you will have to think of conditions like Wiskott-Aldrich syndrome, where child will have repeated infections and eczema and thrombocytopenia. So that is another differential what we have to think. And if you have a giant platelets along with normal platelets in the peripheral smear in a typical case scenario like ours, then it goes in favor of ITP. If it is uniformly megaplatelets, it's more towards inherited thrombocytopenia syndromes or Bernard-Follier. If it is mixed picture like, normal and giant platelet, then it goes more in favor of ITP. You also have immature platelet fraction, IPF. So is another clue like that gives you clue towards like, is it an ITP or some other cause or marrow pathology?
I think you're muted.
You can hear me now?
Yeah, we can hear you.
So, size of the platelet, again, very important, gives you a very good clue as to which direction you need to go for the workup. So as we had seen before, this is a very large, this is a large giant platelet, which almost is the size of a red blood cell. So just briefly, these are all genetic disorders. Shirisha, can you just go over them briefly?
Yeah, the list is quite big. I will say like, if you have inherited thrombocytopenia, then you need to divide them mainly into micro, normo, and macro. So micro mainly like your Wiskott-Aldrich. Normo is like, your X-linked as well as star syndrome will come into normo. And mega, in mega, you will have conditions like MYH9 anomalies, gray platelet syndromes, and some more other conditions like, all listed here. The list is quite big. So the commonly seen one, what I have seen in our clinical practice have mentioned. And of course, in mega, you also have Bernard-Solier syndrome, along with this list that has been given here.
So just, for the sensitization, that very often we see patients who are labeled as chronic ITP. And they're going around, getting small bleeds here and there, somebody giving them platelet transfusion, somebody giving them steroids. But sometimes you must remember that these are all conditions which also look like ITP. But when a lot of children don't have chronic ITP, so if you want, you have to question your diagnosis, and it is often more cost effective to do the workup. Nowadays, it's not that expensive. So before labeling a child as chronic ITP, I think we should think about some inherited disorders as the cause of low platelets. So as Shirisha just said.
Just to add one sentence, we have like a few patients. I am sure you all would have noticed like Fanconi's, CAMT, all these conditions generally tend to treated as ITP for few years. It goes on for 1 to 2 years, and then ultimately they get diagnosed. Even Wiskott-Aldrich also. Wiskott and Bernard-Solier, von Willebrand, platelet type of von Willebrand, and Fanconi and CAMT. These are the few conditions which gets treated as ITP for longer periods. So as Deepa said, like, nowadays we have a facility for genetics which will clinch the diagnosis.
Yes, so it's very important. Like when you see small platelets, you think of Wiskott-Aldrich, male child, X-linked deficiency with, skin eczema, recurrent infections, high Ig levels. They often present with a gastro bleed. So again, very important that not every low platelet is ITP, and sometimes you might have to do a genetic workup to find out what is going on. So Anand, now this kid has isolated thrombocytopenia, platelet is 5,000. Would you do a bone marrow in this patient or no? And why? Yes or no? Why yes? Or why no?
Yeah. So in this child, it's controversial, but there are some absolute indications for bone marrow, which first I will talk about. So in the history, if you get a history of prolonged fever or child presents with fever, or there is significant lymphadenopathy, because in ITP also we see some sort of cervical lymph nodes because they're coming off some viral infection. But if you see a significant lymphadenopathy, and if there is severe pallor, you would expect some form of anemia, especially rural areas because of iron and B12 deficiency. But if you see severe pallor, or you see hepatosplenomegaly, or if you get a history of bone pain, hurried breathing and everything. So these are some of the, and on physical examination, if the child has short stage, microcephaly is there, or if there's an extra digit, extra thumb, this thing. These are some of the red flags on history and examination. And of course, like peripheral smear, when I said, if you see blasts in the peripheral smear, or if you see teardrop cells or some sort of bone marrow failure kind of indications, then definitely these are the absolute indications wherein you have to do a bone marrow. Coming to this child, of course, he is a well-looking child with some form of microcytic hypokalemia, reactive lymphocytes. On examination, I assume it's completely normal. So in this, whether to do a bone marrow is a big contentious issue. So for this, if you go by the Western literature, they say no need to do bone marrow. You just give the steroids and everything. But in India, I think it's different for us. In fact, myself and Dr. Nitin Shah, we were the authors of ITP standard treatment guidelines this year. So we had this issue discussed with the eminent experts and everything. So we came to a conclusion that if we are starting steroids, you have to do a bone marrow even in a case of ITP. This is what we practice. We thought that we should not preach what we don't practice. So we came to a conclusion. We will do bone marrow if the child is receiving steroids. I think, yeah, we can discuss that. Sorry.
Sirisha, does she agree? Bone marrow, yes or no?
Yeah, as Anand just said, like, if you have a facility where you can see the complete smear examination, you are completely sure that, not only clinically, also by smear, and you have a platelet, immature platelet fraction that is also supporting. One can, if somebody can decide on not doing the marrow and give steroids, it's fine to go ahead. But that should not be a general practice. Most of the places, they don't have a facility for smear examination, IPF. So forget about IPF, even smear examination is also difficult in many of the places. Going by that, it should not be a generalization that, thrombocytopenia can be given steroids without marrow. So in our center, like, we don't give steroids without doing the bone marrow. In young children where parents prefer not to go for steroids, like less than 1 year, less than 2 years, in those kind of age groups, we just give IVIG, wait for the response. If they don't respond, then we convince them to go for marrow and steroids. Otherwise, like,
we also have a similar practice.
We prefer not to give steroids without marrow.
Yeah, I think that is, what about you, Dr. Sandhya? Do you agree? No steroids?
In presence of atypical factors only, marrow will be considered new case. Otherwise, before giving steroid, we will, if we are considering steroids and not watchful observation, then definitely marrow should be done.
Yeah. Just remember. Yes. So let's go ahead since it's already 4:40. So the bone marrow was done in this case. There was markedly increased megakaryopoiesis, some immature forms hypolobulated. So the findings were supportive of diagnosis of ITP. So Dr. Anand, briefly, quickly, what would you see if you did a bone marrow on an ITP patient?
So generally, I don't do bone marrow to diagnose ITP, but I would like to see if the cellularity is fine, because in my mind, I'm thinking whether it's a subtle presentation of Fanconi or a CAMP, like Dr. Sirish was mentioning. So I would look at the cellularity, which is very important. Okay, and at the abnormal cells, like if there are any abnormal cells, blasts that are there, and of course the other megakaryocytes are present or not. So these cellularity, blasts are things that which I would look for. If these things are fine, and of course if megs are increased or decreased, because now the whole pathogenesis, we feel that there is a problem in the production also. So megs sometimes are decreased, but I think it's a clinical follow-up that you see and the cellularity that are important to finally label this patient as ITP, or is it a part of inherited bone marrow failure, wherein NGS and genetic tests would be helping us.
Okay, so normally this is what we usually see. This is a very cellular marrow that we see, and megakaryocytes can be increased. So Sandhya, what is ITP? So now we know this patient has ITP.
So very clear already by this time that this is this immune destruction of platelets going on. The IgG type of antibodies are formed, autoantibodies, usually idiopathic in this age group, in pediatric age group. And these antibody-coated platelets are removed from the circulation by binding to the FC receptors on macrophages. These antibodies have specificity for GP2B3A, this receptor we discussed, which is responsible for aggregation platelet to platelet interaction. And sometimes it is also against the receptor GP1B. Mostly in children, it is acute, and we may find in 50 to 55% of cases, we may find a history of either viral infection 2 to 4 weeks prior or an immunization. Chronic is usually seen in an elder age group, maybe adolescents and adult women. And already has been discussed that chronic has alternative diagnosis also should be considered. So we'll discuss that.
Okay. So now what are the three phases of, now we don't call it something like acute and chronic. We have renamed it a little bit. So just
ongoing state. So any case which is less than 3 months old, diagnosed, newly diagnosed is a newly diagnosed case, less than 3 months since diagnosis. Then when it goes on from 3 months to 12 months, it is persistent. And when it is present beyond 12 months, it is chronic. Now, there can be episodes of remission, intermittent remission and relapsing condition. There can be a persistent state, but the pathophysiology remains the same, that autoantibodies, IgG, formed against the platelet GP2B3A most commonly. Now for chronic, like has been discussed at length already, but I would like to add one ASH publication here, which is from our Noida government hospital, where ITP children were studied, and those who went on to become chronic, alternative diagnosis like already discussed HIV, hepatitis B or C, lupus, then congenital conditions like immune deficiency were also found. So common immune deficiency and X-linked thrombocytopenia, then combined immunodeficiency, and even immunological conditions like psoriasis and leukoderma has also been reported. So the concept is that if a child in this age group, if somebody is going for chronic, look for an alternative diagnosis.
Yes. Yeah. Don't keep giving steroids again and again.
And second line, third line.
Yes. So Sirisha, quickly. So children with newly diagnosed ITP, platelet less than 20, more than 20, with no or very mild only skin symptoms, should they be admitted to the hospital to an ICU as an outpatient in the ward? What is the recommendation of the American Society of Hematology? And of course, our guidelines too.
Our guidance, yeah. So more than 20,000, definitely no need for even hospitalization, not even in a ward, I will say. But less than 20,000, it depends on where they are coming from. If they are coming from remote area where the medical facilities are not good, if their understanding is poor, so or if the child is very young, more prone for understanding is not good, prone for injuries. So in those kind of situation, probably the admission may be warranted, but definitely not in ICU. In our unit, we don't admit them even with 3,000, 2,000 platelets in ICU. We admit them in the ward because we all know that mega platelets are functionally good, and then they're less prone for serious bleeds, especially life-threatening bleeds like IC bleeds or life-threatening mucosal bleeds. So otherwise, less than 20,000, if their understanding is good, they are from local area, they have only minor bleeds, then no need for admission.
Yes, that is very important, that we have to explain to the family. Of course, as we had said, if they come from a remote place, you can't send them back if they live like 400 kilometers away or something. But definitely everybody need not go into the hospital, and you need not give platelet transfusion immediately. People order SDPs, people order multiple RDPs to be given to a patient whose platelet count is like 20,000 or 25,000, saying, oh, he might have an ICH. So very important. The good practice statement is that patient should be seen by a hematologist within 24 to 72 hours so that the family can get a reassurance and they can work up the patient if required, etc. So Dr. Anand, if the child has no or very milder bleeding, should he be observed or should we give steroids right away?
Yeah. So yes. So if the the dictum in treating the ITPs, treat the patient, not the platelets.
Correct.
So I would say that I will just I will suggest that we observe rather than giving steroids, especially because the patient has even no minor bleeding also, or we can just be watchful. If the patient can come for follow-up.
Yes, so very important, again, reassure the family. They should have a number to call. If there is a problem, they should know where to reach. So keep all that in place and then tell the patient to be in observation. It's very scary for the family, which is understandable. But I think one thing good happened after COVID is people are wary of steroids now because of Mucor and all these things that they hear.
Yeah.
So if you tell them, I give you steroids, then they say, no, we don't want steroids. We'll wait and watch. So I think steroids, people are a bit scared now. Yeah. So what is the data, Anand? You can go over the slide.
Yeah, so I mean, there is a perceived benefit that corticosteroids are better, but when you see the data, the observation versus corticosteroids, they're almost equivalent, and the remission rate, we see a spontaneous remission rates in ITP, which is close to 60%. The same goes along with corticosteroids. So there was no difference in reduction in major bleeding as well. So I think apart from this, if you start steroids unreasonably, then you are exposing the patients to unwanted side effects.
So I think it's very important that families should understand that just giving the steroid is not going to cure the problem. And you can still have bleeding. You have to be careful, especially in a hyperactive child. You know, we always worried that they'll bump their head or something like that. So Sirisha, what about now? I have money. So I want to buy IVIG. I would not wait for observation. What is the data?
So, first of all, like, if we first look at our clinical practice, most of the times we consider IVIG where there is a need of rapid raise of the platelet count,
Correct.
which is a condition like IC bleed or life-threatening bleeds like continuous mucosal bleeds. Even minor mucosal petechiae along with skin bleeds, we don't consider IVIG in those situations. So going by that, I will say like, the IVIG indications are narrow. And as the steroid, Dr. Anand just highlighted, similarly, like, IVIG also like, the states the same the recommendation in both the groups, whether you give IVIG or you just observe. So the difference is not much.
So I think that's very important because sometimes the family has to raise a lot of money when there is no major bleeding just because you're treating a number like 5,000 platelets. So I think IVIG again is not recommended if there is a mild or no bleed and just not treat the numbers. So again, the dose, right? Shirisha, the doses have changed over the years. People used to keep people in the hospital for 5 days and give small doses. But can you tell us something about the IVIG dose?
So ASH 2019 guidelines clearly says 0.8 gram per kg single dose is good enough to control the bleeding. So we are not treating the number, we are treating the bleeding. So just that dose is recommended right now. In the past, people were giving like 2 gram per kg. There are publications in Indian pediatrics in the past, like even 0.3 in our situation, where IVIG is expensive and when people cannot afford 0.2, 0.3 gram per kg is also good enough to control the bleeding.
Yes. So again, very important, give the proper dose of IVIG. Anti-D, Sandhya. Quickly.
Won't dwell much on it, not available. And just to highlight that this is not the same as is given in a RH sensitized mother. So it's the IV version. And it works by lysing, by attaching the RH positive red blood cells. So it can be given only in RH positive patient. Number one, there is a risk of hemolysis because actually we are working by inducing hemolysis and making our macrophages busy and our platelets are spared. So some conditions, one is, of course, there is risk of hemolysis, and two, baseline hemoglobin should be decent 10 and above so that it can be given, though not available, I think.
Yes. So Anand, what kind of steroids would you give and how long would you give the steroids?
Yeah, I think this is a big debate till now that what kind of steroids, how many days, because adults use one dose. Pediatricians, we are used to 2 milligram per kg per day. They give for months together. But recent ASH guidelines has done extensive work and just told that we should use 4 milligram per kg per day of steroid for 7 days. After that, no tapering, sudden stop is what is the recommended. No there is no more advantage of giving dexamethasone when compared to prednisolone. So the recommended dose is, steroid form is prednisolone and 4 milligram per kg per day, max of 120 for 7 days, no tapering.
Yes, that is very important because sometimes we see people taking steroids for 6 weeks, 8 weeks, with a slow taper going on. So the recommendation is only 5 to 7 days. You stop it suddenly. You hope the platelet have come up by then. This is acute ITP. So once you have that rise by 4 to 6 weeks, the patient should be stable. So we would say that don't give too much of steroids. There's no role of people giving methylpred like Solumedrol IV, keeping the patient in the hospital. So these are all options, but this is the recommendation. So mucosal bleeding. Sirisha, if you have non-life threatening but mucosal bleeding, of course, we don't have anti-D. So I suppose IVIG is the only option that we have. Steroids, if you want to.
Yeah.
You give
So,
them IVIG steroids.
So as we just discussed in last couple of questions, like, if the mucosal bleeding is only significant, then in the sense like it is causing hemoglobin drop or requiring transfusion, in those kind of situations only, we go for IVIG or anti-D. I'm sure most of us have moved away from anti-D nowadays, and then we are sticking to IVIG or steroids in case of life-threatening bleeds. And in case of non-life-threatening bleeds, of course, no recommendation for these drugs like IVIG or anti-D.
Yes. So since we are running short of time, so the panel says that if you have newly diagnosed ITP and non-life-threatening bleeds, then they would still suggest that you use corticosteroids rather than IVIG. Sirisha, now the patient has ITP, it's more than 3 months, or they have failed the first line, they did not respond. So what would you give?
So once again, the dictum is same in chronic ITP, treat the child, not the number. So only you have to treat if there is a bleed. So usually if it comes to less than 10,000 in chronic ITP, you notice bleeding tendency. Otherwise, like about that, usually with the trauma or injury only they bleed. Otherwise, they don't bleed as such. So in the past, if you ask like, couple of years back, then we all would have gone for this huge exhausting list. Azathioprine, danazol, dapsone, cyclo, or vincristine and all. But nowadays, most of us have moved away from those drugs to TPORA, either L-Trombopac or Romiplastin. So it depends on the patient choice, like, whether how we choose Romiplastin, L-Trombopac, it depends on the compliance. If you think that they are compliant, if you think that they are going to stay in PIVO after taking the medication for some time, they recommend these 2 hours, but at least 1 hour. So if they are going to stay without taking the food after taking medication, then choosing the L-Trombopac is better option. But if you think that those 2 points are not fulfilling, then you can also go for Romiplastin once in a week, subcutaneous. And though they say the dose, like, 2.5 mg per kg, that is arbitrary less than 5 years, like 25 above that, 50. Majority of us start even at 10 years, 25, and then see how they respond. I'm sure, like, in Indian scenario, but compared to earlier, the TPORA cost has significantly come down. In the past, we used to do like that, even for bigger child, like starting with small dose, like 25 mg and all. But now we can all use the proper dose with a decreasing cost.
Yes. So again, as we said, every time we have to read the guidelines and change. Initially, we used to give Azoran and all these things, and then we would move to rituximab. But now we know that if you don't respond to first line, your options are TPO versus rituximab. So obviously, what would you choose?
So ASH 2019 guidelines clearly states that your rituximab comes after TPORA. So first, like in a bleeding child, once you tried steroids, IVIG, then you go to TPORA rather than rituximab. Splenectomy comes for chronic ITPs after TPORA, after rituximab, then the splenectomy comes.
Okay. So just as quickly, Sirisha, can you go quickly over this slide where how Romiplastin and L-Trombopac work?
So as we can see, like, the L-Trombopac, so it mainly runs through the JAK-STAT pathway. At receptor level, Romiplastin works, whereas at lower down level JAK-STAT pathway, the L-Trombopac works. So that is what I can see. I can't zoom in. I've logged in through the mobile.
No, it's fine.
Sorry. Yeah.
No. It's so basically these are new drugs which stimulate the bone marrow to produce more platelets. So they're not immunosuppressive. So there's a completely different group of drugs. And I think residents and students definitely should read more about it. And again, this is a very busy slide, but lack of time, I'll just go quickly. There are these are all available online. The doses are different for different ages. And Romiplastin is given subcutaneously. L-Trombopac has to be taken orally on an empty stomach. So again, that is compliance issue. Whereas Romi, you have to come once a week to the hospital or go to your local doctor and take it. So there are advantages and disadvantages of both the drugs. So third line now, Romiplastin doesn't work. TPORA is not, otherwise L-trombobag is not working. Now what will you do, Anand? Rituximab or Splenda?
Definitely rituximab. Yeah, first I would go for rituximab in this situation. Yeah, so before giving rituximab, I would ensure that the viral serologies are clear, especially we do anti-HB core antibodies, because sometimes HBsAg can be negative, but we have to look for important is anti-HB core antibody levels we do, and of course serology and we do. And so especially, so rituximab is more effective. We have seen that in adolescent females with more of autoimmune background, this thing causing. So it's a chimeric monoclonal antibody against CD20 cells which are producing the immunoglobulin. So therefore, we are attacking the source of production of this immunoglobulins antibodies. So that's how it acts. And of course, the vaccination and everything should be becomes ineffective sometimes after this because there are no B cells to produce the memory cells. And of course, at last, splenectomy in children we seldom use, especially only in very severe bleeders phenotypes only we recommend use, and not less than 7 years because the risk of OPSI is more. So that's how I place it.
Yes, so it's very important to time. If you've given rituximab, you can't give vaccination. Then if you want to plan splenectomy, you have to do it accordingly. And then quickly, Sandhya, we would have a lot of time, so a minute. We also have to think about platelet function disorders now. We looked at platelet inherited, where you don't produce or you have large platelets. But there's also a whole set of disorders which should remember that platelet function disorders, where the numbers may be good, but the platelets still don't work or aggregate.
So platelet function studies will be abnormal in this case. That is the whole idea of sharing. List is difficult, but the 3 steps that we discussed in the very first step is adhesion of platelet and secretion of granules, that is activation, and aggregation defect. So these 3 steps, the defect can be one, the receptor can be deficient, or the receptor can be under the attack of antibodies. In such situations, the function will not be there, though the number will be normal. Bernard-Soulier is specifically discussed because it has both number and function problem. Others will have all normal numbers with your collagen. So we discussed the various steps. Yes. Collagen is involved, VWD. So platelet function studies will be abnormal. A mention here is that when bleeding time may not be done in some setups, then TFA is coming up. So that should be, if available, can be utilized, though diagnosis remains a difficulty.
Again, we know people live in smaller towns, peripheries. So make sure you talk to the pathologist, make sure you ship the sample properly. I think that is very important. Even coagulopathy, we have to spin the tube and then take out the plasma and freeze it, then you can ship it. So make sure you have all this information, because sometimes sample is not collected properly or it's lying somewhere. So all these are very important when you send platelet and platelet function studies. Again, these are all available online of what you will send and what will be the abnormality. I think it's very difficult to go over in one lecture. NGS, I think we had discussed. Shirisha, very important. Just go tell us why NGS is so important.
So as we have already seen, when we are going through the chronic phase of the ITP, then we have to revise our diagnosis. Is it actually ITP or something else? Inherited marrow failure, primary immunodeficiencies, platelet type of von Willebrand's disease, or inherited thrombocytopenia syndrome. So a lot of differential should come into mind, or it can be systemic lupus erythematosus. Of course, their NGS will not come into picture, but for other conditions, what have been just listed, the importance of NGS comes into picture, and then reach the diagnosis, I would say.
Again, very important, talk to the geneticist or talk to the lab, because there can be point mutation, there can be deletions, there can be additions, there can be problem in the intron, problem in the exon. So we should know which set of labs to be sent, because it's an expensive test. And if you send the wrong set, you might not get the diagnosis. So again, this is very important, again, at resident and student levels, to know that which diseases, what mutations is carried, and send the test accordingly. So now we go to case 2. How much time do we have? 10 minutes more?
Max 20 minutes.
Max 20 minutes. Okay, so quickly we'll do the next case, short. So this is a 4-year-old boy who presented with bruising tendency in his arms and legs. His mother mentioned that the bruising typically appears without an injury. At the age of 3, he had one episode where he had severe epistaxis, and it was quite severe that he required 1 unit of transfusion. The family So there was a family history of bleeding on the maternal side. The patient's mother and maternal grandmother had some abnormal bleeding characterized by epistaxis and menorrhagia. Patient's mother was transfused 5 units of blood at the time of her delivery, and the patient was not on any medication at the time. And I think this is again very, very important. But as pediatricians, we always get these patients, and when you ask for a family history, they tell us right away, but somehow the gynec never remembers to ask the family history of how the maternal uncle is or the maternal aunts are. So again, very important to take a detailed history when the patient comes for a bleeding disorder. So the physical examination revealed multiple ecchymosis all over the extremities. Again, this is a very busy score system which helps us to diagnose how severe the bleeding is. It might be difficult to do on the outpatient basis, but if we can do it, it is very useful, because then it gives you kind of an idea as to how severe the bleeding was, and from the family history and other members in the family also. So these are again questionnaires which are available online. You can print it out and fill it up, and this will give you an idea of to how severe the bleeding was. So what are the bleeding tests you will usually do, Shirisha, when a patient comes to you? So CBC is normal here.
Other than your complete blood picture, looking at the platelets count, size, and bleeding time, your PT, APTT, and bleeding time, once again, like, you can divide into two, like whether it is a Duke's method or Ivis method. The Ivis method is the standard, gold standard. That is like inflating the cuff and then building up the pressure and doing it in a proper way, but you may not be able to do in a smaller child. And once we reach to stage where whether it is primary or secondary, then you go ahead and channelize, like, which test to do next. So if bleeding time is prolonged, then you also have to go ahead and think, is it a platelet function defect? Whereas PT, APTT is normal, platelet count is normal or abnormal, then it can, and bleeding time is prolonged, it could be platelet function disorder. Whereas if coagulopathy is there, like, it's a secondary hemostasis, then PT, APTT will be abnormal. So then you go ahead and investigate in the line in the form of doing mixing studies and all. So first and foremost is like clinical history, where whether it is a girl or boy, inherited or acquired, primary or secondary. Then in primary, then look at the bleeding time. If it is prolonged, then also do, other than also do von Willebrand factor, not only platelet function defect, it could be platelet type of von Willebrands also. So in both the directions, we have to go ahead and do, and then you also have to go ahead and do platelet aggregometry, in which you have in which test, like, you will come to know, like, what type of problem you are looking at within the platelet function disorders, whether it is Glanzmann's, Bernard-Solius, or secretion defects, or is it a platelet type of von Willebrand disease. So those kind of clues you get in the platelet aggregation test. So and on the other hand, if it is coagulation, then of course, after the mixing studies, appropriate factor quantitative assay, you have to go ahead and do it.
Okay. So Dr. Anand, can you tell us a little bit about the mixing studies and the correction studies?
Yeah. So when you see a prolonged APTT, it can be because of two things. One is deficiency or due to an inhibitor. In studies, what we do is we add the equal proportion of the factor that is deficient. So if it gets auto-corrected, then it is factor deficiency. If it doesn't get corrected, then you are dealing with inhibitors, which is more common in like hemophilia or acquired hemophilia kind of a thing. But if you have a factor deficiency, again, when there is prolonged APTT, you think of factor 8, 9, and other abnormalities. So accordingly, you can place your diagnosis.
Okay, so again, we should go in a stepwise manner. Sometimes it might take some time. The patient has to be waiting in the OPD or come back the next day, because we can't rush the pathologist. So again, it's very important to do a mixing study to find out if there is an inhibitor which is acquired, or for an older person, especially if they can have acquired hemophilia. But usually in pediatrics, it is an inherited disorder. So we have deficiency. And once it is corrected or not, we get an idea which factor level to send. So in this patient, factor 8 was done, which was 20%. Normal range is 50 to 150%. Again, it's very important to know that you can have 50% activity and still lead a normal life. The von Willebrand antigen was 18% and the RCO was 15%. So both of them were low in this patient. So the diagnosis here is von Willebrand disease. Now, Sandhya, can you tell us a little bit about von Willebrand disease?
So von Willebrand factor is an ancillary. It's a factor present in released by platelets also, and also in the subendothelium. It acts as a bridge, and it increases the efficacy and stability of factor 8. So, like we discussed, that factor 8 is also low, but it's in the mild range rather. So, any mild factor 8 deficiency cannot be reported unless we comment or unless we test von Willebrand factor antigen, as well as the functional assay with von Willebrand ristocetin cofactor, which is responsible for the good efficacy, long half-life, and sustainability of factor 8. And thus, von Willebrand factor also acts by working both in primary and secondary hemostasis. In primary, we discussed it is at the level of adhesion with platelet adhering to the collagen. And in secondary, it is acting for the directly acting for efficacy and for a good functioning of factor 8. So the types are 3, and there is a lot of overlap, and usually autosomal dominant type 1 is the most common, where there is quantitative defect that is not enough von Willebrand factor, and the phenotype can be hardly any bleeding to just menorrhagia to severe bleeding and episodes requiring attention or consultation. Then type 2 has 4 types, where there is qualitative defect depending, there is this dysfunctional von Willebrand factor, and the inheritance can be dominant and recessive. Bleeding phenotype is again variable. Type 3 is the most severe to understand, and there the bleeding can be very, very severe with menorrhagia and postpartum bleeding, and this accounts for very less % of cases.
Yes, so again, it's very important, as she said, that especially if you have a history of females having menorrhagia, girls, when they come to you with, and as teenagers, you always must consider von Willebrand disease and not, just plain old hemophilia. When you consider having low factor 8, but we have to rule out other causes also. So this is a flow chart again, which is quite available online again, and there are ASH guidelines again on the internet, which you can pick up, and it will tell you how to manage these different types of von Willebrand disease. But of course, you will involve a pediatric hematologist at the time once the diagnosis is made. Very often the girls especially have menorrhagia. They might have to be put on hormonal pills to reduce the hemorrhage. So again, this is very important to counsel the family and give them the medicines properly. And again, treatment. Anand, can you just go quickly over the treatment? I think we have a few minutes left now.
Yeah. So, the one which is readily available for most of the pediatricians in government institutes are plasma products. So, generally, cryo is a good source of von Willebrand factor. We can use it 1 unit per 10 kilo. And of course, desmopressin DDAP can be effective in type 1 disease and some form of type 2 disorders, wherein the IV dose is 0.3 microgram per kg, or we can use nasal puff spray also, or there is a now immunate wherein there is a von Willebrand along with factor 8 combination. And if the factor 8 is very low, like in type 3, we can use factor 8 concentrate also.
Okay, so again, we have different products available for different problems, and pre-op and post-op, again, the guidelines are available. Again, very important that every state has a hemophilia society. So please help the patient become a member of the hemophilia society. They get support from other parents also. There are a lot of government programs now, government hospitals, which give factor support. So very important that they get into this loop and they don't feel that we don't have any help. The government hospitals often have supply of factor, and they can help them. There are hemophilia clinics and OPDs running. Sirisha, quickly, Hemlibra.
Hemlibra, it's a, emicizumab.
Yes.
So it is an emicizumab. It is it has structural homology to factor 8. And it bridges it replaces the factor 8 in the coagulation cascade and then enhances the coagulation. It is very good drug. It doesn't have inhibitor tendency. You can, there are 4 trials like Heaven 1, 2, 3, 4 trial, where initially they looked at the efficacy once in a week, 1 to 3 mg per kg they have tried. one in that like efficacy of the drug has been tested initially. Later, whether once they know that it is effective, then they also tried with inhibitors, without inhibitors. It is effective in both the ways. So it is given once a week subcutaneously over a period of 2 weeks, followed by once in 15 days. But practically, most of us give once in a month, not once in 15 days. And usually we do give lower doses like 0.3 to 0.5, also not exactly 1 to 3 milligram per kg. And it is very effective even at that dose with the inhibitors. So we know that the incidence of inhibitors in hemophilia A in severe hemophilia A is to the tune of 25 to 30%. So in that kind of scenario, it works very well. And then many of the parents, when they come back, they say that they forgot that they have hemophilia, which is very, very nice to listen to that statement. So and luckily, we are very fortunate to say that, in Telangana, in some of the places, in Hyderabad, Khammam and all, Hemlibra is free of cost. So I'm sure in some of the places that program may be running in other states also, but in our state, it is there.
Yes, that is again very important. As pediatricians, you must ask for this medicine, and it really works great. We had a little baby who had an intracranial hemorrhage, and he came out through. And once he was put on this drug, he has not had any hemorrhages since then. So this is something again which residents and students should read up, and those who are working in the government or in the IAP should encourage the administration, because this drug really works well. And it's only once a month subcutaneous, so no venous access, no time spent in the hospital of finding the vein and giving the IV. So it's so easy to work with this drug, and I think it's really working miracles. And some patients do reach that target of no bleeds ever. So I think that is very important in hemophilia, to take care of these children. Just like in thalassemia, we have to fight for them. So I think with that, I would end the panel. Any questions from the audience or from the panelists? Any comments?
Just one comment, Deepa.
Yes.
So while working up for all hematological causes, as a pediatrician, we should never forget about thinking any non-accidental injuries. So in this, like whenever we see bleed, that should also come as one of the differential.
Yes.
Especially when you have retinal hemorrhages or hemorrhages that have clear marks and all, we have to suspect in AI.
Yeah, nowadays when children are left with daycare or with a child minder, and you come home from work and you see a bruise on the head, and the kid fell down, but just fell down doesn't give you a big bruise. So again, yeah, history is very important.
Thank you very much, Dr. Deepa and your whole team, Dr. Anand, Dr. Sandhya, and Dr. This is, you're not named. Sorry, I forgot that. Sirisha. It was a wonderful coverage. While going through the session, I was realizing that a lot of new things have come up, which we as a general pediatricians are not very we don't know many of those things. Especially the last you mentioned about Hemlibra. I'm sure many of the general pediatricians are not very aware, but at the same time want to know, in pediatric population, how common is the inhibitor? I understand in adult or elderly it's common, but in pediatric population, is it so common?
So inhibitor starts right from the 20th exposure onwards. We have seen the kids even after 5-factor exposures also they developed inhibitors. The incidence of inhibitors in hemophilia A is to the tune of 25 to 30%. So going by that, it is seen in children often.
Okay, because as it is, you don't require a very regular kind of a factor VIII or cryo replacement to hemophilia patient. And in that again, is it?
Yes, nowadays that is how this Hemlibra also is developed, because the theory is that the half-life is short. So people in the US started keeping patients on weekly therapy or 3 times a week. So, and the problem is the viral inactivated factor, which is derived from plasma, is less likely to give you antibodies compared to the purified or the manufactured factor VIII. And the second thing is, the most severe hemophilia you have, the more chance of antibody, because your bodies don't see it. Body doesn't know that there's something called a factor 8. So they see it as a foreign protein. So that is the reason that patients who are on chronic therapy to prevent bleeds were ultimately getting inhibitors, and they were now not responding to this 3 weekly. That's how the extended factor was developed, that it's a long-acting preparation. And when that didn't work, then Hemilibra has been developed.
No, but for understanding of a common pediatrician and what you have been conventionally taught, we would use hemophilia once there is some kind of an active bleeding start. So you are telling us as a preventive, and this part you
Yes.
didn't discuss here. So can you just tell us what are the criteria for preventive factor 8 or Hemilibra use? Is it a standard guideline that,
Yes.
I mean, are you going by the
World
factor
Hemophilia.
concentration levels in the plasma and then give it, or is it kind of a standard protocol to give it periodically at a fixed time? What's the logic?
So the basic idea of giving prophylaxis in hemophilia. So if you look at hemophilia, mild, moderate, severe only bleeds. Moderate at times they bleed, mild only after injury they bleed. Severe, they are prone for significant number of bleeds. When you are giving factor with after bleed, you have to give at higher concentration in one go. Then they are like, body gets more sensitized and you have more tendency to develop inhibitors. Not only amount of factor, also your genetics also decides whether you get inhibitors or not. That is another aspect of discussion. However, if you are giving prophylaxis, then you are giving smaller dose at regular intervals. Then you are converting severe hemophilia into moderate hemophilia. By doing that, you are making them less prone for bleeds, less amount of exposure. That is how you can cut down on the inhibitor formation. That is why prophylactic therapy, even with the factor, is very much there in place from the beginning. But nowadays, prophylaxis, instead of with the factor, now with Hemilibra, if you are giving, then it is like, very convenient. With factor, you have to give 2 to 3 times a week, 3 times ideally, but 2 times you are giving. Now with the Hemilibra, you can give prophylaxis just once in a month. So which is very convenient for the patient, and overall the cost also, like, some mild difference will be there if you calculate.
See, the problem in our countries, we are giving on demand because of financial resource problem. Whereas the World Hemophilia Federation has said that it should not be on demand, it should be prophylaxis, because they think the target is no bleed, no joint damage, which with our resource constrained country, we cannot follow, because we cannot have so many vials for so many thousand patients. So we try to ration that the worst one will get more, the less, of course, mild will never get, because they are mild. They can go with Zamic and all the other treatments. So we are trying to actually set perfectly. We are converting a severe to a moderate. But because of that, they develop inhibitors and then all the problems come. So
in our hospital in Noida, we are practicing extended half-life products are being given on prophylaxis basis to patients. Suppose they are staying very far and they don't have access to factor, then board exams. So for the wrist joint and all, where we know that they don't have a scribe and they will be writing for good 2.5, 3 hours. That is where under trial, these, like Dr. Shesha said, that they are available free of cost. So we also have it. And because of these trial, we are able to give it to, but then you have to select the patient who needs it most. So if a patient can be kept on extended half-life product, even once a week administration, because of resource constraint, we are administering once in 5 days also, and maintaining such patients on EHL products. And then those who are who have no access and we know they are going to have some challenge in coming weeks and months, then we are putting them on these under trial drugs, which are available for free, like Hemlibra, and FIBA is also available here. So, but inhibitors are observed and have to be screened, especially if there is a surgical procedure, because product is given left and right in high doses. That is also one absolute indication to look for inhibitor.
Something about you discussed a lot about ITP, thrombocytopenias. Now you gave us a huge kind of information on platelet dysfunction. From a general pediatrician perspective, this topic far more discussed than practically seen. So it may be a practice bias, you being a hematologist seeing more. Can you just tell us how common is this problem and when you really start thinking of this problem? Platelet dysfunction.
Yeah, we do see at least, 4 or 5 cases in a year, right, Shirisha?
As a hematologist.
Yes.
Actually,
I
I
am
should
discounted to
say,
see one
being in
cases in
South
2-3 years,
India,
right?
yeah, 4 or 5 cases in a month we see.
Oh,
Because our
Yeah.
part of the nation, like you see a lot of consanguinity. So and majority of these platelet function disorders are autosomal recessive.
right.
So going by that, we see lot of Bernard-Solier, Glanzmann's. So these are the two common variants what we see in the platelet function disorders.
So those are like, what are your clues towards it? I mean, are these the patient who are kind of thought by the pediatrician referred to you, or they are something which is missed and you pick up? If so, then what's the starting point of thinking of this problem, first of all?
So when the pediatrician comes to know that like if this child is repeatedly bleeding right from the young age, with or without consanguinity, majority of the times consanguinity will be there in these autosomal recessive disorders, then you suspect that this is probably platelet function disorder and you refer to the hematologist. Then you look at the platelet size. After that, you look at the bleeding time. And subsequently, you go ahead and investigate with the platelet aggregation as well as, nowadays genetics are available and all. So, and the strong family history, whatever the rare bleeding disorders we have, like majority of them also will have strong family history. Being autosomal recessive disorder, every child will have 25% chances of having the same problem. So the family history is another important clue. So young age, repeated bleeds, strong family history, consanguinity, and bleed that requires intervention to stop the bleeding. So these are the clues for pediatrician to refer the child for further investigation, I will say.
Chetan,
Do we get
Bleeding
any
out of
idea?
proportion.
Do we get idea of platelet size is going to give some clues for this?
Yes,
MPG?
sir. Yeah. A platelet count, if once you suspect platelet function disorder, normal count will go towards Glanzmann. Low platelet count goes towards Bernard-Solier. You look at the size, megaplatelet will go towards Bernard-Solier or other inherited thrombocytopenia syndromes list. Dr. Deepa has already shown big list. And whereas small size platelet will go towards Wiskott-Aldrich syndrome and microplatelet disorders.
but in case of Bernard-Solier, if your mega platelet going to be miscounted as RBC, then how you will get the large size documented? Because they will be going into RBC lineage and counted in the RBC, right? So how do you get the large size of the platelet in that case?
The
So
pathologist will have a look at the
Yeah.
smear. He can tell.
Okay,
machine
okay.
will give you mean platelet volume, but
Yeah.
the pathologist will tell us exactly whether it is a platelet or
Okay.
something else.
Fine, fine. Chetan Bhai and Rajendra, please take your questions.
Apart from the hematologist, as a general, normally we see apart from ITP, a lot of dengue, and then there comes thrombocytopenia and everything. Something about the mean platelet volume, we have talked about it, immature platelet factor, and something about now there is a called quantities. EDTA-induced pseudo-thrombocytopenia. We get a lot of cases, and then we do in citrate, platelet count suddenly comes normal. So can you give some clues and
I think Anand had spoken briefly, right? Anand,
Yeah, ma'am. Yeah.
Yeah,
So some
pseudothrombocytopenia and
patients
IPF.
have sensitivity to EDTA. Yeah. So some patients have sensitivity to EDTA wherein the platelets just form like a satellite around the RBCs and they're missed. So that is known as satellitism. In that, through depicted, if you do just a finger prick at the bedside and do a smear, or you can send in a citrate so that you can get away with the EDTA sensitivity part of it. And second, coming to the IPF, it's a very, it's like it's a window into the bone marrow. It says that when your platelets are being produced or not. It's like a reticulocyte equivalent of the platelet, right? So if IPF is more than 10%, we say that the platelet production is good and you need not worry. Even the platelet counts are like 10,000, 20,000, and you're worried that they may come when they will come up and everything. But if you see a high IPF, you are more ensured that the bone marrow is thing, and you will see a platelet count rise in a day or two. That's what we infer.
For platelet transfusion, what are the general interesting facts about the platelet transfusion, or what are general important points to be remembered when we are going for a platelet transfusion, Deepa or any of the panelists?
So basically, we must remember that when the patient whole blood is in your body, it's at a normal temperature of 37 degrees.
Correct.
But the minute you take it out of the body, nobody wants to live together. The red blood cells, the platelets, they don't like to live together. The red blood cell likes to be cold. So it has to be in 4 to 8, whereas the platelets have to be in an agitator at 20 to 24 degrees. So platelets, if you don't agitate the bag, it will clump. So when you have to give platelets, keep everything ready. The vein should be ready. Don't struggle for 40 minutes to put a Vigo. The platelet, when it's issued from the blood bank, right away, it should come to the patient's bedside. You hang it and it should go fast. So don't give platelet over 1 hour and 2 hours. It should finish immediately. And then if you're getting 2 or 3 platelets for an older kid, other 2 should be kept shaking. Either you give it to the relative or the attendant to keep it shaking. Don't keep it on the bed, on the table for half an hour, 45 minutes. Don't issue platelets during lunchtime. A shift change. So nurse will leave it here. The medical officer will not sign and check. So platelets quickly from the agitator into the body, the shortest period of time. Don't keep it in the fridge. Again, OT, when you're taking a patient to surgery, for example, and you need 6 platelets, the surgeons always ask for more. They never use it. Then some genius will bring it from the blood bank and keep it in the fridge in the OT. Keep jab mangenge, tab we will give it. But please don't keep the platelet in the fridge. Then it will become halwa. It will not be platelet. And patient cannot be given IV. He has to eat it. That's the most important thing. Shake, shake, shake. Thank you.
That's very
I'll-
important. Carry on.
I will give one case scenario again. I think this is from our side now. Here is an ITP who has to be operated. He is at present at a count of say 20,000. As you told us, we are not giving anything, but now he has to undergo a surgery, and surgery is scheduled on say 20th of this month. So when do I give IVIG to this patient so as to get his platelets up, or steroid to this patient so as to get, is it a predictable increase in the platelet after certain time? That's what is my question. How commonly we are reliable, we are having that? Because my surgeon will come and if the thing is not ready, he will come after 1 week. I'm staying at Peripheral place. My anesthetist also takes his own time. So tell me how predictable this rise is there. When do they increase?
48 to 96 hours around.
So the surgeon has to
yeah.
stay there for 48 hours window.
No, you can give it 4 days. Once it is up, it's not going to disappear.
Okay.
If you get
So
a
it will
response,
stay at least for a few days.
so you'll be
So by the time you would have done surgery and your platelet would have started going up.
Okay.
So we give usually
this is
3 to
about the
5 days
steroid
before
or
the
this is about the
surgery.
IVIG? This is
Both.
about the steroid or IVIG?
both will take 48 to 96 hours. So what if you give it within before 4 days, you will know that whether you have to give something else or not. For example,
Okay.
if you give steroids and after 72 hours, it doesn't get better, you might have to give IVIG and then wait for 2 more days and then do surgery.
So which steroid you will give for this purpose? Any Pradi or what?
Oral prednisolone will work. If the patient is taking orally and is able to tolerate, oral should be fine.
So I should give about 4 days ago and see the trend.
You go for splenectomy only for chronic cases. So by then they would have faced, the efficacy of the steroid. So they just take 3 days and they come, they check the count, and then you will be reassured that the count has gone up and you are
Not
safe.
splenectomy. I think he's saying any other surgery, not splenectomy.
No, not a splenectomy.
Not
Now this
splenectomy.
patient come for an emergency. See, he has an head injury and I'm suspecting and I have to open now.
Then you have to give all the 3. Then you have to give steroids. You can give IV steroids then. At this case, when you have head injury, yes, IV steroids, you might have to give a platelet transfusion. You might have to give IVIG all together. You can't wait for that. And splenectomy, same thing as, Shirisa said, as patient may not respond, but if you have a good confident surgeon, the minute they clamp the splenic artery and vein, the platelet count will come up. You have to be confident to open the abdomen. If they clamp immediately.
In fact, we have done emergency splenectomy.
Emergency splenectomy, Anand.
For ITP, I have not.
Case of ICH, yeah.
Vaccination of
In
any
adolescent females.
vaccines.
Yeah, that's a big thing, but we have done one case.
So now surgeon has come in picture related to surgeon only. Every surgeon has practice to advise bleeding time, clotting time. What is your opinion about that now?
We don't, at least I don't do it because I don't have a good person to
Not
put the
available.
needle at the right angle. So we don't do it. Unless you have a good old technician.
No. What about bleeding time and clotting time? Now they
We
say
don't do it.
that's
We
why I
do
want to say,
PT,
because
APTT and fibrinogen. We don't do
that,
PT usually.
that message has to go everybody. Otherwise,
Yes.
the surgeon did right bleeding clotting
BTCT.
time with it. Yeah.
So clotting time is completely
Rajendra,
absolutely
no more
tested.
medically safe, no more medically safe BTCT.
Yeah,
Nowadays.
yeah.
It is only PT and PTT. It's no more medically safe. CBC, PT and PTT. Yeah.
Yes, either that message should go. That's
Yes,
my
yes,
feeling.
sir,
Yeah.
correct. BTCT still they do.
Yeah.
Because
Yeah.
for CT to prolong, it needs 50% of the 50% of the factor to come down.
Yes.
So for PT for PT or PTT to prolong. For CT to prolong, clotting time to be prolonged, 50% of the factors to be reduced.
Yes.
Yeah.
No, even more than that. If I don't
More
miss, less than 10%.
Yeah.
It should be less than 10% to come on bleeding clotting time.
It's operator dependent.
30%.
Now you mentioned about one more thing, that is IM versus IV anti-D in the treatment of ITP. Is that different molecules or the same molecule given through different
It's a different molecule.
Molecules are different.
molecules.
Program and Winro. The
Okay.
Winro was Mankind. But
Okay.
have you used NAM? I don't know. I've never used.
Yeah, I have
Yeah.
used in the past, but not in the recent times.
Yeah.
In the past, we have
Which used
used.
to come from Canada.
Adults, it has more usefulness, especially with.
Yeah.
Yeah, Palliraman,
It
you
used to
can
be
take
one
your
of the
question.
effective drug, but nowadays, like it is not in use at all.
And it's
So
not
many
better.
others are available with good safety profiles. So why take
Absolutely,
risk
yeah,
of-
yeah, true.
Common challenge in clinical practice is the neonatal thrombocytopenia. Can you just briefly throw some light on that? With thrombocytopenia on day 1, thrombocytopenia on day 7, thrombocytopenia on day 15. And when I'm saying day 7, this child was okay for first 3 days. Whatever reason he came on day 1, day 2, he was all right. His platelets were normal. Day 7, I document. And third one coming on day 15. How do you, a healthy full-term baby delivered with day 1 thrombocytopenia, later on day 7 and day 15?
So
yes.
thrombocytopenia classically divided as early and late, sir. Early will be like, within 48 to 72 hours. Late will be beyond 72 hours. Early will have factors like, maternal factors, maternal drugs, maternal ITP, which is like, reflecting low count in the baby. Or then sepsis comes into picture, sepsis and other causes like intrauterine infections or inherited problems and all. Whereas late will have sepsis on high on the cards, not the maternal factors. Late thrombocytopenia, late onset thrombocytopenia, sepsis will come high on the cards as the first differential. Incidence of thrombocytopenia in NICU, I'm sure you all will agree that it is more than 50%, 50 to 60% in NICU babies. So majority of the times you see that, and then whether it is IUGR related, hypoxia related, or sepsis related, or immune mediated causes. So these things will come more into picture rather than inherited marrow failures or reduced productions and all. So first, these four, 5 causes will come into picture, neonatal causes, rather than the rare causes like reduced production.
So mainly you think about alloimmune or autoimmune thrombocytopenia, like whether you think that what was the previous pregnancy in a well child at least. So the platelet antigen is what the baby has. The mother produces antibodies. So paternal antigen. So the patient will be well, but develop severe sudden thrombocytopenia. The second thing is you think of mothers who already have ITP and their transplacental transfer of antibodies happens. So this again is a well child who develop ITP. Mothers who have autoimmune disorders like lupus, Sjogren's, they have anti-SSO, anti-SSB antibodies, so they can transfer that. We have seen neonates who are well non-septic. So non-septic, you think of any immune-mediated thrombocytopenia, whereas a septic kid, of course, you think about infections, central line, umbilical catheters, candida as a cause of sudden onset of thrombocytopenia. So well versus sick child.
In fact, 2 common scenarios of neonatal are preeclampsia and IUGR baby.
Yes.
What is their kind of a natural course of those thrombocytopenias?
They usually get better after postnatally if they are given enough oxygen, like they don't have any hypoxia continuing that, for example, they don't have any meconium aspiration or they were near term otherwise. I think they get better over some time. I don't think ever somebody has been chronically thrombocytopenic. They recover with proper nutrition, multivitamins, etc., etc.
And
PAMOF
madam,
is the, yeah,
RH,
please.
RH isolation normally we get in second pregnancy. I think platelet isolation we get in first pregnancy. Am I right?
First pregnancy, yes. First pregnancy also.
First pregnancy, the severity in second pregnancy is more. So you have to be more cautious when you are doing vacuum deliveries or other forms of deliveries which can cause injury to baby.
I think the principle is same, right? Principle is same. Platelet positive and platelet negative. Yeah, Paliraman, you wanted to ask something.
Yes.
Madam, usually it is said major factor deficiencies won't present in the neonatal period with exceptions. With exceptions. Can you state some of the factor deficiencies which is presenting in the neonatal period? For example, factor 13 presenting as umbilical wound healing, late umbilical cord fall, like that. Sometimes rarely factor 7 deficiency presenting as an intracranial bleed in the neonate, like that. Any common things you can state? Usually it is said they very rarely present in the neonatal period.
Yeah, you're right.
Yeah.
We have some 3 cases of afibrinogenemia, which have presented with severe umbilical bleed, and after some time they presented with bad subgaleal hematoma, orbital bleed. Saving the eye was a challenge, and getting no fibrinogen. I mean, the diagnosis was difficult because outside this child was being treated as factor 9 deficiency, which definitely is not there, because this is a problem of the common pathway and where PT, APTT actually will be normal. I mean, they will be both
abnormal.
Both abnormal.
It was like administering the factor and then getting some value and diagnosing that, okay, this is, so one is brother, sister, and so if the phenotype can be very, very severe.
How do you diagnose factor 13 deficiency? Because again, there is no specific test.
That is just for
factor 13, sir,
so.
hypofibrinogenemia is one thing what we have seen. Hemophilia, very rarely, they can have even bleeding from umbilical stump. Post cord fall, we have seen very rare, but majority of the times post cord fall bleed is factor 13. Hypofibrinogenemia, as Dr. Sandhya stated, and rarely hemophilia. Other than that, hypoprothrombinemia, one baby presented at 1.5 months of age, but not in the neonatal period, factor 2. And other than that, acquired causes, as we all know, vitamin K deficiency can present, which will also have acquired factor deficiencies, 2, 7, 9, 10. So in that also you can have spectrum of bleeding.
Anand, you can tell us something about what sir asked, factor 13 deficiency.
Diagnosis. How do you diagnose?
So essentially in that the platelet count is normal, PT-APT is normal, your fibrin, all the coagulation tests are normal. The screening test would be 5% urea clot solubility test. But the factors, clot solubility test, wherein if it's a minor deficiency, you will miss that. So that's why factor 13 assay is preferable. So that is the way you are diagnosing factor 13.
Yeah, but it's very interesting. You make a clot and you leave it overnight. And next morning you come and check, the clot should be stable. There should be a round clot there in the tube. If it has disintegrated, that means there is some problem. So that's a simple test which you can do in the lab, but of course you want to prove or validate, you need to send the factor level.
PAMOF coagulation issues in ICU, thrombocytopenia associated multi-organ failure, is a big thing in the PICU nowadays. Can you just give some kind of elaboration on that?
Yes. So commonly when we think about sepsis, right? So we see severe gram-negative sepsis, multi-drug resistant organisms, Klebsiella and Acinetobacter and all these organisms, which usually we see in oncology patients. Patient can go into septic shock and develop DIC. So basically the problem in a PICU is the development of a DIC, whatever has instigated the DIC. You can have patients who have post-cardiac surgery. I think when you have massive cardiac surgery and repairs and stuff like that, where you put a Teflon graft or something can trigger the DIC again. So first we need to know what is the cause of this trigger, try to treat that. Secondly, we need to treat with, of course, broad spectrum antibiotics and supportive care. There is really not much. You have to monitor the PT, PTT and the platelet count and give the blood product accordingly. And then that's about, I think, what you have to do.
How is the utility of this new tag?
TEG.
Yeah, take
Yeah, so the TEG is usually useful when you have transplants, I think liver transplants, where you know which product to give, but many of the hospitals may not have it. Those who are doing transplants or liver diseases may have TEG, and TEG is very useful. It quickly gives you what product to select, whether you have to give cryo, FFP, or a platelet transfusion.
Madam, whether PF 100 and PF 200 has literally replaced the bleeding time
Yes, probably.
nowadays?
Yeah.
Because bleeding time properly to be done, it should be by a hematologist, but it's very, very rarely done. Very, very difficult to do also.
Yes.
So on particularly less than 3 years, it should not be done, it seems, because of the child this thing. So it is mainly
Exactly.
done now, the thing. So
Yes.
instead of bleeding time, we can go for PF platelet function test 100, platelet function 200.
One more question related to neonatology. The controls taken in neonatology for comparing the your PTT values. I mean, many times your lab person will take the control from adult for a neonatal bleeding profile, and that's what happens in most of the labs. How does it reflect onto your interpretation of coagulation profiles?
So the controls are run as a part of their QA and QC. With every sample, a control is not run. So what is given in the bracket as control is the lab control, but we have normograms and tables where people have published what is PT at, pre-me PT in a newborn, PT in a 1 week old. So we refer to that normogram with the patient's result to tell the family or to tell the pediatrician that this is okay, this is normal, because you can have a PTT of 57, I think, in the newborn.
Yeah.
Normally
at that end, they are giving the printed report as 55 PTT to a general pediatrician or to anybody who is not well versed. It's a huge bleeding profile, which is far beyond 1.5 of INR, right?
Yes.
And then the whole problem starts. There is always a tendency to push so much of plasma here and there.
Correct.
So
Very
ideally, that
question.
should be the
Very
control
good.
should be run with the neonate for the age, and unfortunately, that control is never given on your reports.
Yes, but we have tables available online and in the books. So we can keep, if you're doing neonatology, you can print one out and keep in your NICU. There is a pre-me chart and there's a term chart. So you can check which day of life and then say whether that's normal or not for this child.
Wonderful. Any more questions? Wonderful session. So many additions to our knowledge. Thank you very much. Absolutely wonderful. Initially, I thought you were just taking platelets because went on for 1 hour, but you covered so nicely because those are the issues which we sometimes overlook. And then you could easily cover a nice and good question answer session. I'm sure my colleagues are also equally happy.
Great, sir.
Thank you very much. Thank you very much. We'll definitely have you again and again on this platform. It's a very kind of informative session. Thank you very much. All my colleagues, Dr. Chetan, Rajendra, Palni, I think they make the session more vibrant. So it's always good to have such kind of people. And of course, our President IIP, Dr. Upendra Kinzwadekar. And thank you very much, faculty, for sparing your time, valuable time. And we'll keep calling you again. Please come and enlighten us.
Sure, sir. Thank you so much for giving us an opportunity. We read a little bit and learned more. So thank you so much.
Yeah.
It's very true.
It's over to Dr. Nilima for announcing the next week's program. Thank you very much.
Thank you, sir. Thank you.
Yeah.
Thank you, today's panelists. It was a wonderful session. I learned a lot. New things, many new things learned today. So next time we are continuing with the hematology topic, and we have Dr. Manas Kalra. He will be telling us about how not to miss cancer in children, tips for pediatricians. So that is the topic for next Tuesday. See you all on next Tuesday. Thank you.
Thank you very much. Thank you very much.
Okay, bye. Yeah.
Thank you all. Thank you so much.
Thank you.
Mahesh made it complete, the discussion.